Meniere's syndrome describes a combination of 4 symptoms: fluctuating, sudden, or progressive hearing loss, typically in one ear, pressure or fullness in the affected ear, ringing or roaring tinnitus in the affected ear, and attacks of vertigo. Although it is a benign condition that is controlled with dietary modification or medication and resolves in 60 to 80% of sufferers, Meniere's syndrome can disrupt the family and work lives of patients who suffer from it. The hearing loss of Meniere's syndrome usually, but not always, starts in the low tones. Less commonly, it will affect high frequencies first. Most often, hearing fluctuates or changes over time. Often, decreases in hearing signal that syndrome is entering an active phase, when attacks of vertigo may be more common. Meniere's syndrome can also occur after sudden, partial, or total loss of hearing in one ear. The pressure or feeling of congestion in the ear with hearing loss in Meniere's is at least in part an illusion created by the brain. When hearing is impaired, the brain interprets the loss as physical plugging of the ear. A patient may be convinced there is wax, fluid, or a foreign object obstructing the ear canal, even though examination will show no such obstruction. Because of this relationship, the illusion of plugging will correlate with hearing impairment. An increase in congestion may signal the syndrome is in an active phase. When hearing is better, the sense of plugging diminishes. Like the feeling of congestion or plugging, the ringing or roaring tinnitus heard in an ear affected by Meniere's syndrome is another illusion created by the brain. When hearing is lost, the brain attempts to fill in the sound lost from the damaged inner ear in the same way a person who has had an amputation may develop phantom limb syndrome. As in the feeling of plugging, an increase in tinnitus often signals the syndrome is in an active phase. When hearing is better, the sense of tinnitus diminishes. Vertigo is the illusion of movement in space when you are not in actual motion. It is the feeling you may remember after rolling down a hillside as a child. The vertigo of Meniere's syndrome is usually one of spinning and less commonly rocking or swaying. Rocking and swaying sensations are more common in vertigo caused by migraine. Patients with Meniere's syndrome often do not first come to the doctor with all 4 symptoms at the same time. It is not uncommon for patients to have a history of a few spells of vertigo followed years later by the development of hearing loss in one ear, or, vice versa, a history of unexplained hearing loss in one ear followed some years later by the development of vertigo attacks. Until all 4 symptoms are present, the diagnosis of Meniere's syndrome may be suspected, but not confirmed. While there are several diseases that may appear similar to Meniere's syndrome, in most patients the cause of Meniere's syndrome is unknown. However, there are conditions that are strongly associated with the syndrome. The 2 most important are head trauma and migraine. Individuals with a history of concussion or head trauma, especially if the trauma causes hearing loss, are prone to develop Meniere's syndrome. The full-blown development of Meniere's syndrome in these patients may occur months or years after the injury. The same may also be true of patients who lose hearing from infectious causes, like viruses or bacteria. Although vertigo associated with migraine is discussed more fully in another video, patients who have a history of migraine are at twice the risk as the general population of developing Meniere's syndrome. In many of these patients, migraine with or without headache occurs before, during, or after an attack of Meniere's. It can be difficult to determine whether the migraine symptoms, for example headache, visual changes, or other symptoms, are the cause of or the result of the Meniere's, or whether in these patients, Meniere's syndrome and migraine are really just 2 sides of the same coin. There are families where Meniere's syndrome is very common, suggesting a genetic link causes the condition in some patients. Unfortunately, the true cause of the condition remains unknown at present. The inner ears of patients with Meniere's syndrome develop evidence of too much fluid, called endolymph, in one of the compartments. That is the reason why another name for Meniere's syndrome is endolymphatic hydrops, or hydrops. Whether the apparent overaccumulation of endolymph is the cause or effect of Meniere's syndrome is unknown. However, it is because of this observation that treatment of Meniere's syndrome usually starts with measures designed to reduce fluid pressure in the inner ear. The future hearing of patients with Meniere's syndrome cannot be predicted. The hearing of many will stabilize at some impaired level or return to normal when the condition is inactive. Unfortunately, some patients eventually lose all hearing in the ear affected by the syndrome. To date, there is no treatment proven to change the outcome of hearing loss in the Meniere's syndrome. In up to 30% of patients with Meniere's syndrome, both ears become affected in some way. Whether a patient who first comes to the doctor with Meniere's syndrome in one ear will eventually develop the condition in the other ear cannot be predicted. However, there are a couple of general observations worth keeping in mind. First, patients tend to develop symptoms in both ears fairly early in the course of their illness. Therefore, the more time that passes with the symptoms in only one ear, the less likely that it will occur in the other ear. Second, many of the 15 to 25% of Meniere's patients who develop bilateral disease will have the full-blown condition in one ear and milder symptoms in the opposite ear that may not progress. The possibility of developing the condition in both ears is an important consideration when more aggressive treatments that are sometimes required for very severe Meniere's vertigo attacks are contemplated. The treatment of Meniere's syndrome follows a hierarchy, starting with conservative measures that may slow or stabilize the condition while presenting minimal or no risk to hearing or balance function. When patients have failed to respond to conservative measures, more invasive treatments such as injections of the affected ear or surgery may be undertaken. When patients are severely affected by attacks of vertigo, procedures that destroy the balance function and sometimes the hearing may be recommended. It is important to remember that the treatment of vertigo is directed towards stopping the spinning attacks that cause nausea, vomiting, and severe temporary imbalance. These attacks, typically lasting no longer than a few hours, should be considered separately from the general unsteadiness that patients with Meniere's syndrome may develop, either as a result of the disease or the treatment required to stop the severe attacks. Generalized unsteadiness may be helped by balance exercises, and in some cases physical therapy, but does not improve with surgery or injections of the ear. Treatment of Meniere's syndrome often starts with limiting the amount of sodium or salt in the diet. This recommendation is based on the observation of too much fluid in the inner ear compartment. Limiting sodium to 1,500 milligrams or less per day is recommended. Although this sounds like a lot, it's the amount found in about 1.5 tablespoons of regular soy sauce. Remember that sodium is present in very high amounts in most fast foods and prepared foods. You should keep track of your sodium intake as you go through the day. For some patients, limiting or eliminating caffeine from the diet can help. Also, some patients will find that limiting or eliminating foods and beverages that can trigger migraines may also reduce their Meniere's symptoms. These foods may include chocolate, nuts and nut products, red wine, fermented foods, aged cheeses and meats, and foods that contain MSG. Depending on the intensity and frequency of the symptoms that a patient may present with, a diuretic, otherwise known as a water pill, may be prescribed when the diagnosis of Meniere's syndrome is made. In milder cases, a diuretic may be prescribed if sodium restriction and other dietary measures have failed. Discuss the side effects of the medication with your doctor and make sure that you have your response to the medication monitored. Most patients on a diuretic should have periodic monitoring of their blood chemistry. Anti-nausea medications are prescribed for patients who have vertigo attacks to take when they are nauseated. Medications administered orally, under the tongue, intramuscularly, or rectally can be used. If you have a history of vertigo from Meniere's attacks, you should keep some of this medication with you. Unfortunately, taking medication for nausea, such as meclizine, known commercially as Antivert, regularly will not prevent Meniere's attacks. Although it is not available commercially in the United States because it has not been proven effective, beta-histine, popularly known as Circ, is used in many other countries for the treatment of Meniere's syndrome. A prescription for this medication can be sent to a compounding pharmacy by your physician if you wish to try it. When a patient with mild symptoms develops breakthrough symptoms, such as a few attacks of vertigo that occur in a row or a sudden change in hearing, a course of steroids administered orally or given as an injection through the eardrum may be recommended. Discuss the risks of oral steroids with your doctor before taking them. Finally, although these general remarks about the conservative treatment of Meniere's syndrome apply to most patients with the condition, they do not apply to all. Some patients do not find dietary modification or taking a diuretic reduces their Meniere's symptoms. As you learn more about your personal Meniere's syndrome, it's best to be flexible and keep an open mind. There are two types of drugs that have been injected into the ear to treat Meniere's syndrome: steroids and gentamicin, which is an antibiotic. The two types of drugs are used differently. Steroids are used to provide temporary relief from Meniere's symptoms. Gentamicin is used to damage the balance system in the affected ear to give longer-term relief from attacks of vertigo. The use of steroid injections into the ear for Meniere's syndrome is popular, although the benefits have not yet been proven in controlled studies. In some patients suffering through a flare of their condition, injection of the affected ear with steroids seems to quiet the symptoms and give them at least temporary relief. It is not known how steroids may help Meniere's syndrome. Gentamicin is a potent antibiotic most commonly used to treat severe infections. It acts as a poison to the ear when given through the eardrum, often allowing destruction of balance function without requiring surgery and hospitalization. This is especially helpful for elderly or medically infirm patients with severe attacks of vertigo. The benefits of gentamicin injection for Meniere's syndrome have been proven, but it is a treatment that is generally reserved for patients with severe attacks of vertigo that has not responded to conservative treatment and who have poor hearing. 20 to 30% of patients treated with gentamicin injection will have further hearing loss. Often, a series of injections is required before the treatment is successful. If the treatment is effective, patients will notice a mild sense of vertigo that starts 5 to 7 days after one of the injections. When enough of the drug is absorbed by the inner ear for the treatment to benefit the patient often feels a subtle sense of rotation away from the injected ear. This is usually a mild sensation that may cause unsteadiness, but rarely nausea. Sometimes unsteadiness is severe and requires the patient to use a cane or walker, usually temporarily, until the brain and body adjusts. Note, Meniere's vertigo attacks that occur during the series of injections simply mean that not enough of the drug has been absorbed by the ear to work. During a series of injections, the function of the inner ear may be monitored with hearing tests and balance function testing. In 20 to 30% of patients injected with gentamicin, hearing may be lost. If enough gentamicin is administered, this form of treatment can be up to 94% effective in stopping attacks of Meniere's syndrome. For both drugs, the risks of injection include a perforation or hole in the eardrum. Although it occurs rarely regardless of the drug used, the risk of this is slightly higher for steroids than gentamicin, since a side effect of steroids is to slow healing. Another risk is infection. This too is more common in steroid injections than gentamicin injection. There are 3 operations in wide use for the treatment of Meniere's syndrome. Endolymphatic sac decompression. This is an outpatient surgery that offers relatively low risk with a reasonable chance of successful control of vertigo attacks. Vestibular nerve section. This operation is reserved for patients with severe attacks of vertigo who have failed conservative treatment or sac decompression and yet still have useful hearing in the ear with Meniere's syndrome. Labyrinthectomy. This operation is considered the gold standard in the treatment of Meniere's syndrome, against which all other treatments are judged. The endolymphatic sac is a sponge-like structure that resides in the bone of the mastoid behind the ear, between the mastoid and the tough layer of tissue that surrounds the brain. It is involved with the regulation of fluid balance in the inner ear. In the operation, the bone surrounding the sac is removed. It is an outpatient surgery that requires a little hair shaving and a small incision in the shadow of the ear. It is not especially painful and does not require an extended duration of time away from work and family responsibilities. Patients usually stay one night in the hospital or go home after a few hours. In about 92% of patients, attacks of vertigo are mild after surgery or resolved after 2 years. 85% have stable or improved hearing. The risk of hearing loss is 1 to 2%. Vertigo attacks can recur after endolymphatic sac decompression. The best patients for this operation are those with useful hearing in the affected ear and vertigo that continues despite conservative management. The risks of the surgery include infection, bleeding, loss of hearing in the operated ear, and continued attacks of vertigo. Very rare but serious risks can include facial nerve injury and weakness, leakage of cerebrospinal fluid, and meningitis. In other literature, you may hear of the endolymphatic sac shunt. In this operation, a plastic sheet or tube is inserted into the sac in the hope of draining more fluid from the sac. Unfortunately, this measure offers no benefit over decompression and has a higher risk of cerebrospinal fluid leakage and loss of hearing. For these reasons, sac shunt surgery has been abandoned by most surgeons. For patients who have frequent and severe attacks of vertigo and yet still have good hearing, vestibular nerve section is 95% effective in stopping the attacks. This is an operation that is performed in conjunction with a neurosurgeon. A small amount of hair of the scalp behind the affected ear is clipped, and a quarter-sized hole is made in the skull. An endoscope allows a view of the hearing and balance nerve, which is the 8th nerve, without requiring much manipulation of the brain. The part of the nerve that carries the information from the inner ear is cut. After surgery, a 3 to 5 day hospitalization is typical, followed by several weeks of balance exercises at home or with a physical therapist before patients can return to work and driving. While the operation stops attacks of vertigo in all but 5% of patients, 26% of patients will have mild, permanent imbalance after surgery. This will be especially noted in darkness, after taking sedating medications or alcohol, or with rapid movements of the patient's head towards the site of surgery. In addition to the 5% risk of failure and a 2% risk of hearing loss, there are other risks. There is a small risk of temporary or permanent facial weakness. Although very rare because it is an operation performed near the vital structures of the brain, additional risks of vestibular nerve section include leakage of cerebrospinal fluid and meningitis. Like any surgery that involves work on the skull, headaches may occur after the surgery. They are usually temporary and mild, but in rare patients may be longer lasting. Extremely rare complications of this surgery are stroke, paralysis, and death. For patients who can no longer tolerate their attacks of vertigo and have poor hearing in the affected ear, labyrinthectomy can dramatically improve their lives. In appropriate patients, the operation is nearly 100% effective in stopping attacks of vertigo. In the operation, the lining of the inner ear is removed through the mastoid. A little hair clipping and a small incision in the shadow of the ear is required. It is not especially painful. Patients usually stay 3 to 5 days in the hospital to allow the vertigo that follows the surgery to stop. For many, several weeks of balance exercises at home or in physical therapy are needed before they can return to work and driving. For some patients, balance recovers sufficiently after 10 to 14 days to allow a return to work and family responsibilities. As in vestibular nerve section, many patients will have a persistent and usually mild unsteadiness that will be especially noted in darkness, after taking sedating medications or alcohol, or with rapid movements of the patient's head towards the site of the surgery. Because the inner ear is removed, all remaining hearing in the affected ear will be lost. There are strategies that may help overcome this loss that your doctor can discuss with you. As in endolymphatic sac decompression, the risks of the surgery include infection and bleeding. Very rare but serious risks can include facial nerve injury and weakness, leakage of cerebrospinal fluid, and meningitis. When reviewing the information that is available from a variety of sources, including the Internet, keep in mind that Meniere syndrome is a benign condition. In 60 to 80% of patients, it is controlled with conservative measures. Many patients with Meniere syndrome have a warning of an impending attack of vertigo. a change in the hearing, pressure, or ringing, or a sense of flushing or nausea, for example. If you do not routinely have any warning of your vertigo attacks, you should not drive. In a few patients with Meniere syndrome in both ears, severe loss of hearing in both ears results. When hearing loss is too severe in both ears to be helped by hearing aids, patients may become candidates for the cochlear implant. Patients who go deaf as a result of Meniere syndrome tend to perform very well after cochlear implantation.